Thanks for joining us this evening. As he mentioned, I'm Dr. Logsdon. I'm one of the heart and lung surgeons here at Eisenhower Hospital. Today I was going to discuss aortic aneurysms and aortic dissections. I think probably everybody has known somebody who's had an aortic aneurysm or an aneurysm of some such, but yet there's not a whole lot of great information out there about it. And if you start Google searching it, who knows what you'll find and where you'll end up. So let's answer some of those questions. So a little about me first. I originally am from Ohio. I was born in Alaska, grew up in a small town called Lima, birthplace. I lived right by where Neil Armstrong grew up. And then I went to college at Purdue where I studied chemical engineering, and I worked a few years as a chemical engineer at ExxonMobil making petroleum products, gasoline. After a couple years there, I decided to pursue medical school, which was always kind of the plan. And I was down in New Orleans at the time. And so lived in New Orleans for 6 years, and I went to LSU medical school there. Afterwards, I made the transition out west, so the weather keeps getting better and better for me, out to University of Southern California, where I completed a 7-year fellowship that included general surgery and heart and lung surgery. And I completed that in 2021. And so I specialize in heart and lung surgeries. If you ask me what I like to do big operations on the aorta. I like to treat atrial fibrillation and mitral valve repair. So just a quick overview of what we'll talk about. We'll kind of give some basics on the anatomy of the aorta, talk about what an aortic aneurysm is, what an aortic dissection is, what leads to aortic disease, when should you be concerned about this, how do we treat it as physicians, and how to know if you have it. So the aorta is kind of like the interstate of blood vessels. It carries all the blood from the heart out to every part of your body. So when you feel the pulse that you have in your wrist, that blood transitioned through the aorta and went down into your arm. So it's the blood supply for the body. It connects the heart again to every organ and is that transition point for us. And we break it up into a couple different parts. We talk about the part that comes off the aorta is called an ascending aorta because it goes up. We have an aortic arch, which does this, and that kind of carries it across to the back of the body. And then we have the descending aorta that travels downwards. It's very basic. We keep it very simple for us because otherwise we get a little confused. And then it transitions into the abdominal aorta because, as you could probably guess, it's in the abdomen. So the aorta is made up of 3 layers. These layers are all very important. The inside layer we call the intima. It protects the rest of the aorta from the blood. It allows the blood flow to travel smoothly, but it does become calcified at times. It can develop plaques on it. The middle layer is muscle. It's smooth muscle. All of your blood vessels in your body are made up of smooth muscle, and that's what makes it very unique. It's a very dynamic system. It can contract and relax on its own, which helps it to adjust and maintain blood pressure and perfusion to your organs. And then the outside of the aorta, we call it an adventitia. It's a thickened kind of collagen material that keeps everything contained together. And the reason we talk about that is it's important to understand that there are 3 layers when we talk about the diseases of the aorta. So what is an aortic aneurysm? And an aneurysm is just an enlargement of whatever structure you're discussing. We typically use it in terms of blood vessels. And so an aortic aneurysm is an enlargement of the aorta above the normal size. So then you have to ask, what's the normal size of an aorta? Well, it ranges. It starts out very small as a child, and then it progresses to an adult size aorta, which is somewhere around 3 centimeters. But as we continue to age, our aortic wall weakens over time, and it slowly can progressively get bigger and bigger as we age. And so the annual rate of aortic aneurysms in the chest, so saying, if you look at 100,000 people in 1 year, 5 to 10 of them will probably have an aneurysm. And so we discuss those things in terms of patient years, which means if there's 200,000 people, you're going to have 10 to 20 aneurysms a year that are discovered. The picture here on the left is an aneurysm that we had resected here this year. It's a part of the ascending aorta. And if you look here, this is part of the heart structure down here. And then this portion here is the aorta. We'll put a big A on the aorta. And that's a big aorta. So we put a big A on it because we cut it out because it was an aneurysm there. And we'll go to the next slide here. There we go. And we're still annotated. Perfect. Just press the clear button and it goes away. Wow, imagine that. All right, so what is an aortic dissection? Aortic dissection is the separation. Remember, I told you, knowing the layers of the aorta is important, is the separation of one of the layers of the aorta from the other two. Literally, it splits apart. And so this can occur at any point along the aorta. And depending upon where it occurs, it can be a surgical emergency. So if you remember, I discussed this ascending aorta, the part that attaches directly to the heart. If the dissection occurs there, that becomes a surgical emergency. In this picture here on the right, as we discussed, there are three layers: an intima, media, and adventitia. As you can see, you have a rupture that occurs in the middle of these layers, separating one of the layers from the two. And this puts it at a very, very high risk of rupturing. And we'll discuss that going forward. So, as I mentioned, it's a surgical emergency and it can occur on any point of the aorta. This picture here on the right is a demonstration of that. So these tears that you see here along the aorta, which is the structure in white, the structure in red demonstrates where those tears occurred and where the rupture occurred. And so these tears can occur at any point along here, and they result in a different surgical treatment plan depending on where they occur. So a picture of aortic dissection. So this is actually an aneurysm up here. It's an enlargement of the aorta here, and aneurysms can lead to dissections. But as you see, they're actually a split here. Well, maybe we won't annotate today. So it has a structure right here. There's a split down it. That's the split of the three layers of the aorta. So there's two on the right and one on the left. And if you look over here in this picture on the bottom right, you can see an example of what that looks like. And so this is an example of somebody that we took to the operating room and we replaced their aorta from the dissection. So what's the natural history of an aortic dissection? And the reason we're talking about this first is because it is a surgical emergency. So it's important to talk about this because the aneurysms and dissections are related. So if you leave an aortic dissection untreated, it has almost a 50% mortality rate at 48 hours. Within 7 days of leaving it untreated, it has about an 80% mortality rate. And those are the dissections that occur on the part of the aorta that attaches to the heart. So what causes all this aortic disease that we talk about? We all have had family or friends that have probably had aneurysms, and sometimes they don't get operated on, and sometimes they do. So what's determining that? What determines the risk factors that cause aortic disease? So the first one is high blood pressure or hypertension. So as you age, sometimes your blood pressure rises, and that extra blood pressure, as you'd imagine, increases the pressure inside the aorta, and it can cause it to dilate over time. I mentioned as we age, our tissues weaken a little bit, and it can weaken around the aorta. And as it weakens and you have higher blood pressure, it continues to dilate even more. And then there's a small subsegment of the population that has what we call connective tissue disorders. And oftentimes you'll know this because you'll have a family history of aortic aneurysms or aortic dissections, or you'll have had family members that may have died at a young age in their 30s, and you won't know why, but they had an aortic rupture is what most people will say. And there are three common genetic diseases that we talk about that are specifically related to connective tissue. And then there's a fourth that's related to a type of aortic valve that some people are born with. The first is Marfan's disease, and it's a defect in what we call the fibrillin gene. So if you remember, one of the layers of the aorta was the media. It's made up of muscle and collagen fibers. Well, when you have a defect in the collagen fibers, you lose the elasticity of the aorta, and it actually it actually weakens the wall. And so patients that have this are oftentimes very tall, very lengthy, very skinny, very long fingers. And so there's certain things that we look for when we evaluate patients with aortic disease. And if we have some risk factors and we have a family history and we have some of the descriptions that I was describing to you, we'll send them out for genetic testing. There's also a disease called Ehlers-Danlos disease, and it's a wide range of disease, but the version that's what we call type 4 has a collagen defect. And that acts in a very similar way to the fibrillin gene, and it causes the elasticity of the aorta to weaken. Oh. Oh. Huh. How about I just resume the share and try it again? Yeah. You know, the whole annotation thing. All right, how about this? We're seeing it now. Or go. Good. Well, you missed one slide, but that's okay. So hypertension, age, and familial disease. The third type is Loeys Dietz. So we're kind of going through these processes down here. And so Loeys Dietz is very similar to that. The fourth and different subpopulation is patients with bicuspid aortic valves. About 2% of the population have what we call bicuspid aortic valves. The aortic valve is the valve that attaches between the heart and the aorta, and it directs and controls the blood flow in and out of the heart into the aorta. It's usually made up of 3 leaflets, and in patients with bicuspid valves, they have 2 leaflets. And so most people have met somebody who's had their aortic valve replaced at a young age, and that's mostly because they have bicuspid aortic valves. In that patient population, we also screen for aortic aneurysms because it also has a defect in the collagen proteins and the metalloproteinases within the aortic wall that leads to weakening. And so as a physician, when we see these things, we immediately say, okay, let's send them in for screening, and we'll kind of talk about all of that. So this is another example about aortic disease, and it's something called law of Laplace. I was an engineer, so I sometimes can geek out about this, but as you increase the pressure, you increase the wall tension on any structure, whether it's a pipe or a blood vessel. And as you increase the radius, so as it gets bigger, even if the pressure stays the same, the wall tension increases. And so the reason that's important with aneurysms and why we follow them for long periods of times, oftentimes an entire lifetime, is because as it starts to get slightly larger, slightly larger, slightly larger, what can happen is that it can increase the rate at which it grows. Once it reaches a certain size, it will continue to grow faster and faster. And so again, as I mentioned, age is a big factor in this. So as we age and you have your aorta for more years because you're living longer and it gets slightly larger, it will eventually or could eventually get to the size where it needs to be surgically intervened on because it's at a high risk of rupture. So getting to what everybody wants to know, how do we manage aortic disease? So we'll break it down very simply. So we reduce the wall tension. So how do we do that? Well, one way to do that is to lower your blood pressure because it decreases the pressure inside the aorta. And so that's one of the main things that we do. And then we also will screen for genetic familial diseases. So if you have a family history, like I mentioned, or you're have had some of the features that I described previously, will screen you for genetic disease at that time. And that actually helps us put you into specific categories as a patient into how soon you need to be operated on because we know the processes that occur with specific genetic familial diseases. So when do doctors get concerned? So you'll go to your doctor and they'll say, hey, you have an aortic aneurysm, but it's only 3.8 centimeters. You're like, do I need to worry about that? Well, they usually will send you into a cardiothoracic surgeon's office and we'll discuss it. So I'm going to give you some of the guidelines and the keys to the booklet about what we look for. So if your aorta is larger than 4.5 centimeters, we'll typically follow that annually because at that size, we worry about the increased wall tension and the rate of growth. And so we'll usually perform a CT scan. It takes about 30 seconds to perform. We'll give you contrast so that we can see the inside of your blood vessels very well. and we'll continue to follow it. When the aorta reaches about 5 centimeters or larger, we begin to discuss surgery options. We know that as your aorta approaches 5.5 to 6 centimeters, the risk of it rupturing or, as we discussed, dissecting, where one of the layers splits apart from the other, approaches about 6 to 10% a year. It's a pretty high risk to leave a aorta at that rate. And so as we begin to see those changes in the sizes increase, we'll begin to discuss surgery at 5 centimeters. And then if we look at the aorta and it changes very rapidly, again, more than half a centimeter in a year between CT scans, we get concerned that it's starting to grow faster and faster, like we discussed about the law of Laplace, and that would be an indication to operate as well. On the right side, we use an aortic app that's specifically built for having patient conversations. And what it does is it allows us to input some information about you and your size of your aorta over the past couple years, as well as your body size. And we can compare it to what a typical aorta is for your body size. So there are patients that a 4.6 centimeter aneurysm is extremely large for them. And so when we index that, when we compare that to patient size, it actually is very large. And so we'll also put that in and we'll look at your aortic size index. And an index over 2.75 makes us concerned. And so when you come to my office and we discuss this, we'll talk about your aortic size index to make sure that just because you're a small person and your aorta is smaller than what we'd expect, doesn't mean it's not an aneurysm for your body size. So how do we treat it, right? So if the blood pressure medications do not work and you have an aortic aneurysm, the treatment is to cut it out. And so this is a reference to Full House from shows that I used to watch as a kid, but you know, Uncle Joey has it right when he says, just cut it out. And so we take out the aneurysmal portion of the aorta. So how do we do that? That's the main blood flow supply to your body. It provides everything to your brain, to your arms, to your intestines, to your kidneys, to your liver, all the way down to your toes. And so we have to put you on the heart-lung machine and we have to arrest your heart. So meaning stop your heart. And then at that point, we protect your heart with a medication and we pump the blood through your body at that time to keep you alive while we're replacing your aorta. And so depending on where the aneurysm is, determines how much of the aorta we have to replace. Our first graft here, if you can see my cursor, this here, we actually will call the ascending aorta. And so that's just one graft that we do. Occasionally, we have to replace more into your aortic arch. And so these blood vessels that come off the top are going to your arms and to your brain. And so when we have to replace those blood vessels, we have to do a couple different maneuvers with how we pump the blood in your body to allow having perfusion to your brain at that time. But oftentimes we'll replace it and we'll put in a material. This is called Dacron. It's not permeable, so meaning the blood flow can travel through it without leaking out. It has very good, what we call hemostasis. So the blood will not clot within it, but it will not leak out from it as well. And so that's the typical material that all grafts are made from. And then there's a couple other options that we have when we treat aortic disease, and those are involving stents. So you've probably heard about stents going into coronary arteries when people have a heart attack. Well, a very similar technology exists for replacing and treating aortic dissections and aortic aneurysms. And so it's a very similar stent material. It just happens to be significantly larger. And so this picture here on the right, you can see there's a stent in what we call the descending aorta. And so they've placed a stent in here to either cover up a dissection or an aneurysm. And that technology continues to grow and grow each year. And as technology advances, our abilities to replace more and more of the aorta without having open large operations is increasing. And so this is, again, another picture of what I was describing about the future of aortic surgery. That's one reason I went into it. It's one of the last kind of frontiers of heart surgery, being able to replace an aorta without having to do a large open operation, or at least minimizing what we have to do when it's opened, is kind of the future. And as you see here, there's just a couple examples, which to the layperson may not make a whole lot of sense, but there's stents going in all the way across, covering up the blood vessels that go up to your brain. That's the technology that's coming, and that's the things that we're bringing to Eisenhower to help treat your aortic disease. So how do you know when you have an aneurysm. So the problem is most aneurysms don't have symptoms. Most of the time they're undetected. You'll receive a CT scan or an echocardiogram, something that looks at your heart and your aorta for other reasons, and it turns out it's enlarged, and that triggers somebody to say, oh, let's get another CT scan and look at this. And if it is enlarged, usually you'll end up in a surgeon's office at that point. It is rare, but it can happen. Some patients may present with back or chest pain, but it's very, very rare to have your aneurysm that's unknown cause those symptoms and go undetected. There are currently, at this time, no screening guidelines for the general population of people saying, you know, if we took everybody here and said, oh, I want to know if I have an aneurysm or not, we don't have screening protocols for that, because if you went and scanned everybody out here, as we know, it's very rare to have an aortic aneurysm unless you're a cardiac surgeon, and therefore you see all the patients. So my point is that if we were out there to screen like we screen for other diseases, whether that be having colonoscopies for colon cancer, we know that the rate of colon cancer is very high. And so screening for that actually helps prevent disease. We've never proven that screening for aortic aneurysms helps prevent disease and prolong life. And so that's why we have not enacted a guideline for that. And those guidelines will be based on a national level. If you do have a family history, though, those patients, if you have a family history of a bicuspid aortic valve, Marfan's disease, or one of the other connective tissue diseases, or you have a family history that says, oh, I've had somebody who's had an aneurysm that has ruptured or has had an aneurysm and had surgery, that will trigger us to probably screen you for an aneurysm. And when it comes to surgical operations, aneurysms are generally done, quote unquote, electively, meaning it's not an emergent situation that's occurring in the middle of the night because we're worried you're going to die if we don't act soon enough. It's something where we discuss it in the office, we look at images together, and we discuss the plan on how to proceed and when to proceed. The coins flip to the other side, though, when it comes to aortic dissections. Aortic dissections are surgical emergencies, and everyone that's had an aortic dissection can tell you the time and the place where their aorta dissected, because it's extremely painful. It usually presents with severe back pain or chest pain or both. And most people describe it as the worst pain they've ever had in their life. And so if those symptoms were to occur for you, the plan is to come to the emergency room. And at that point, we have protocols here that allow us to get CT scans very quickly and allow us to activate the surgical team if an aortic dissection is presented. And as I discussed before, time is of the essence when there's an aortic dissection. If you have what we call a type A dissection, which again is the ascending aorta, as I mentioned, within 48 hours, about 50% of people will pass away from having an aortic dissection. So every hour matters when you come to the hospital. They are an emergency. And so if you're diagnosed with first an aneurysm, you'll talk to your primary care doctor and get a referral to the Eisenhower Cardiothoracic Surgery Clinic. There, myself, my partner, Dr. Wilson, and our team of nurse practitioners and physician assistants will see you. We'll take a look at the imaging with you, and we'll discuss your size of your aorta and how we plan to follow it up, and if and when surgery is needed. If you experience the chest pain or the back pain severely and you experience it, you need to come to the emergency room. We'll meet, but it'll slightly be in a different setting. We'll discuss the operation and the plan, and we'll take you directly to the operating room then to fix that. So I put some contact information here, but if you're on this web talk, you'll have the information to get to the website. But if you do have questions, you feel free to email me or call our office and schedule an appointment with us. Thank you again. I know it was a quick talk tonight, but I want to leave enough time for questions.